So thank you very much, and greatly appreciate to be here, even though apparently I didn't know we were so high in altitude that it... But I will try to not throw away my presentation, but to make it okay for you. On top of that, you have a French-Swiss accent, so it gives a twist in the presentation, so that should be just to keep you awake after lunch. So that's my conflict of interest. Of course, I'm a co-owner of the TBS patent and so on, so I'll just let you know. So I will go past a certain slide that was already introduced by some of my colleagues, but we all know that osteoporosis is not just density. There is two main factors in the original WHO definition of osteoporosis, meaning the density, so low bone mass and degradation of microarchitecture. Today, in clinical routine, the density is the one who still has the most important weight in a decision, even though we take into account other factors. But you all recognize that slice where you decrease, the density here, you will increase the incidence of fracture. Unfortunately, many of the fractures are occurring in a non-osteoporotic zone, which is that one, but at least 30 or 40, sometimes 60% of the fracture are not, which means that the BMD is not the only factors. And without going to clinical risk factors and everything, at least just as a BMD standpoint, you could, since you are working on a 2D, you could perfectly have exactly the same density, but completely underlying structure, which could be completely different. You could have here, for example, 4 thin trabecular and 2 thick one. In terms of projection, that will be exactly the same density, which means that for a given density, you can have different structure, which could explain why at a given density, some fractures, some may not fracture, is one of the theory. So that's related to bone quality. I just pulled it out a case, very simple case, not too many factors and so on. It's a 70-year-old woman. She came along for medical checkup, and the patient is not taking vitamin D or calcium whatsoever. So clinical assessment, she had a history of ankle fracture, glucocorticoid use, 5 milligrams per day, but just for 5 months, 5 years ago, and stopped, nothing else in her life. BMI about normal, regular consumption of alcohol, and then more than 3 units a day. That's, she must be French. From a certain part of France, I'm French, I can say that too. So, but no other associated risk factor. And when we did the examination, we had the spine BMD T-score was very high, though she had artifact by degenerative disease. BMD of the hip was normal, minus 0.4 or even 0 at the femoral neck, and no vertebral fracture assessment. So we did the FRAX, and we used the American approach with a threshold of 20% and 3% for the hip, and we had 1.5% for hip fracture and 21% for major fracture. So should we treat or should we not treat? So in a case, sometimes we are borderline cases. From a clinical standpoint, we were wondering because of the history, but the BMD is okay, there is a certain point, and one is above the threshold, the other is very far below the thresholds. So the objective of my talks, and I'll come back on that case later, what is TBS? Now you should know by the time. How it's measured and how it was validated and what the potential behind, are the special population, and how to handle TBS in clinical routine. So first, that's the FDA labeling for TBS. They mentioned it's a software that is used as a complement to DXA, so it's not to replace DXA because it works on DEXA machine. It derives from the texture of the AP spine or PA spine DEXA image and have been shown to be related to bone microarchitecture and fracture risk. These data provide independent information of BMD. So let's find out what is true from what is not true, whether or not we trick FDA or not, which is not something easy to do, nor something you want to do. So can we assess bone microarchitecture in clinical routine? Well, there is plenty of technology now. We can have very fancy image from the nano CT here, one can have very, very fine image here on the lamel and so on. But most of the techniques are for research only because highly radiation and so on take a lot of time and just a small region of interest and so on. Now you start to have what we call HRCT or HRPQCT, which is mostly something that can use almost in routine, clinical routine, but still used for clinical research. That was the case, for example, for the extreme CT, although maybe down the road, such a device, if becoming cheaper, will move towards clinical routine. That's something that we could also envision down the road. But now, how much device can we're doing in clinical routine is mostly DXA, and then DXA, we try to, well, we pretend we're extracting information from the texture and microarchitecture of the bone in clinical routine. So you recognize Paul Miller, I mean, the slice of Paul Miller, I mean, sorry, I didn't mean it. So how can TBS assess microarchitecture? Because we're talking about very fancy technologies and we're talking about DXA and poor resolution. And that's always a tricky issue that we have to face because, it's not possible. But I didn't use first the FRAX, but the maze. I changed that very recently. And if you look at the maze made of trees, small trees and so on, obviously, if you want to identify each single tree from this maze, it will be very tricky, almost impossible at that distance. But you can clearly see from that maze the pattern that they are in this image. And even though you don't recognize the trees, you can clearly recognize the pattern, which is somehow much easier compared to the trees. And that's the analogy. Now I come back to the FRAX, so I won't make a lot of time on it, where if you identify the clearing in the FRAX, it's a bit like identifying the projection of the whole on a 2D structure. And with a mathematical model, we'll be able to extract information about how this structure is projected and how this structure, projected structure, is related to microstructure. So that's the concept is based on experimental variogram, and you can have the same BMD value for two different patients and come to something quite different in terms of TBS values. And the experimental variogram is based simply on the variability between gray level, pixel to pixel, a certain distance, a certain angle, and many certain things that I can't go too much in details, otherwise I would have to kill you after. We in the US, it doesn't sound so good. So that's something, and we come out with something from a BMD standpoint to a TBS where high value correspond to good structure and a low value correspond to degraded structure. So that's a theory. Let's see if it's true or not, because I can tell you many bad things. You can say yes, you can smile, you can laugh, but is that true or not? That's another story. So while we stated that the TBS is a bone structure correlated with bone microarchitecture parameters and provide information beyond BMD, we had many studies now, but the first one that was done was the TBS was developed for QCT, not for DXA. And the idea was to whether or not we could extract, find a relationship between the 3D projection and in the 2D projection, and whether or not there is a mathematical relationship between those two. So we study on cadavers and vertebrae, and then we measure the high resolution CT, and we're able to measure also biomechanics and obviously the profit parameters and everything. But then what we start to do in the same time, we start to degrade the resolution of the high resolution CT from 93 micron up to 1500 microns. And that's what we have here. We have a degradation of that image, and we find out that the 2D projection on the degraded image getting close to what we see with DEXA image. And we were able to check that up to a certain level of resolution, the degradation of the performance was very minor. While beyond a certain point, we were losing too much information, so that's why we're not developing TBS for low-end DEXA systems. Having said that, now there is several studies, independent studies, that demonstrated that we have a strong correlation with trabecular number, connectivity, trabecular space, or sometimes index like SMI, which is a road to plate ratios, or even stiffness in biomechanics. And when we start to combine biomechanics plus TBS, different SMI, whatever, we can explain up to 80 to 90% of the TBS in a multivariate model. These have been done by Jean-Paul Roux in Lyon, by yourself, by Resch in Austria, or even by the group of Professor Berezikian in New York. And the QCT was either ex vivo or in vivo, and all the results are concordant, and that's what the FDA are being accepted. So the question is, yeah, but pretty often correlation between the BMD itself and the content and the quality of the bone are pretty tight. So this is extracted from that what you can see in the black ribbon here. It's the reference of Bin Leslie based on 29,000 patients. The correlation between lumbar spine TBS and femoral neck is very low, and the correlation between lumbar spine TBS and BMD of the spine is very low, while the correlation between the two sides, lumbar spine, BMD, femoral neck, is much higher. In other words, that we're not correlated with the BMD side, and the correlation with two different sides on the same BMD is much higher compared to the same side between the structure and the BMD. So every time we had a study, we can adjust for the BMD, and we still have significant relationship with microstructure. So why is the buzz? Why a lot of people talking about TBS? Is it something outstanding? Well, I think there is few things that creating the buzz around that. First, it doesn't require 5-10 minutes, a lot of reacquisition. It just in few seconds, it's based on a DEXA scanner, so that means you put the software on your DEXA machine, and every time you finish to analyze the AP spine scan, you will have a pop-up on the screen, and the pop-up will say, well, do you want to have a new exam been detected? You want a TBS, you press it, and about 3 seconds, 4 seconds after, you get a whole TBS report on your printer or on your screen. So that's very fast. So that's one thing. The second is, which is quite interesting, it's been published now in several papers, I'm just showing one of the papers here, is there is no impact of degenerative disease on the TBS as opposed to the BMD of the spine. Pretty often we have arthrosis or osteophyte on the spine that will create an increase of the BMD. It doesn't impact the TBS value. And here you see a cohort from a colleague from Lausanne here, where they follow up like a patient, so 1,500 women for a normative curve, and you see that the spine without any data cleaning of BMD is slightly increasing over time after the age of 55, 60 years old, where you don't see that on a TBS. And when you exclude the vertebral fracture and osteoarthritis, osteophyte and everything, then you delay the increase, it's getting flat, but still you have remnant osteophyte behind that you cannot exclude completely, and then you don't see that again on a TBS. That was also published on X-rays by Christian Roux and his colleagues, so there is no impact of osteophyte and osteoarthritis on a TBS value, which is quite interesting. Now, the third point that creating some buzz around it is you can retrospectively analyze the past, which means that all the prospective study, all clinical trial, or whatever, all the studies you have been doing, if you still have the DEXA scans, the image, then you can retrospectively analyze it so that you can redo a study you have done a couple of years ago or last week. So that's why, and we see that from the SBMR standpoint, in 2011, you had one abstract without S. You have 19, 30, 34 this year. I counted yesterday morning. So that you have an increase, and in terms of publication, the same. You have an increase because a lot of people putting out their study and redoing it. So that's why we can just test it, whether or not it's of added value. So it's nice to have a potential buzz on marketing facts, but what about the clinical facts? The most important, there is a nice review that's been done by Da Silva, who belongs to the group of Belezikian as the senior authors. And that was a different point that they came out as a clinical evidence and the conclusion in terms of fracture prediction, in terms of secondary osteoporosis, in terms of treatment follow-up and so on. And I will go through some of these with a study to demonstrate it. So first of all, the discriminatory ability, I will go pretty fast because it's the less important one. but TBS has a high fracture discrimination ability in complement of BMD in both men and women. So this is kind of a meta-analysis of all different cross-sectional studies, and all demonstrated systematically that you can discriminate fracture from non-fracture for all type of fracture, hip fracture, vertebral fracture, or all type of fracture for women or for men. So systematically, all the study demonstrating the same thing, even when you adjust for the density of the spine. And the first study that was done was quite interesting is, if you're really adding information on top of spine BMD, the first study that was designed was taking vertebral fracture patients and site match, BMD age match control. So the same BMD and fracture versus non-fracture, and the TBS was able to discriminate both on top of the fact that they were having the same BMD. But more importantly is the prediction. So the prediction is pretty clear now from several studies that TBS can predict fracture independently and in conjunction with BMD, meaning that when you combine the BMD plus the TBS in a model, that you improve it. You have seen the first study that was published in GBMR by a group and completely blind from analysis with Bill Leslie. And out of 29,000 patients, what was really interesting is that when you have, of course, a gradient of risk, when you increase the severity of bone degradation, or when you're decreasing the severity of microarchitecture degradation, and when you have a low BMD osteoporosis and highly degraded TBS, then you have a very high incidence of fracture in that group. And more importantly, what is interesting is the incidence of fracture in osteopenic patients with highly degraded TBS is more important, significantly more important, than an osteoporotic patient with a normal structure of the bone. And that way we have that overlap. So having said that, just focusing on that osteopenic zone, and out of 40% of the 1,600 major osteoporotic fractures that occurred in the study, or about 600 to 40% of them occurred in the osteopenic zone, and 43% of them were having a highly degraded structure, where the BMD was just osteopenic. So is it the only study? Of course not. There is another study, the one was on Lunar, this one is on Hologic, with a vertebral fracture, not all major fracture, but vertebral fracture from Japan. This is a smaller study, but 10 years follow-up, and that was a sub-study. Now they have the full study on men also, which is also working. But the same thing, you combine, you just reverse TBS here, BMD here. When you combine, you have almost 50% 1,000 women year incident of fracture compared to other one alone. So again, you have a combination. The combination improve and just decrease the overlap between fracture and non-fracture. This is another just been submitted actually. The Prof. Lipiner from Bern just give it to me. And the same thing with Hologic, a very smaller group with about 600 patients and follow 4 years, but you have exactly the same trend. Where you combine both, you have exactly the same thing. So if you combine them into a plot, roughly if you have for different studies, hip fracture, vertebral fracture, all fracture, even after adjustment for clinical risk factor and BMD, then you still have a highly significant predictor here with TBS. So let's move to treatment. Can we use TBS to monitor changes across time? And if there is any particular treatment to follow up, and what is the differential effect of different molecules? Are they all reacting the same? So the first one we published was by Craig and also on a subset of the Manitoba, where we had about 3.7 years follow-up, mostly anti-resorptive drug. At 80%, it was alendronate. And that was 500 treated patient versus about 1,100 placebo without naive of treatment, except HRT or stuff like that was excluded and so on. So what's happened here, we noted that we have an increase, of course, in the density at the spine in a treated group versus a placebo. But what was interesting is in the TBS, in the structure of the bone, we had a positive maintenance. I wouldn't say a huge increase, but that's what we will call a positive maintenance versus a degradation of the placebo, which actually was significant. So at the beginning, I didn't thought too much, and I said, well, I'm kind of disappointed. And then Bill Leslie told me, well, you shouldn't, because if we had a major increase in TBS here with anti-resorptive drugs, then it would have been worrisome, because that means you're not supposed to increase the structure of the bone with anti-resorptive drugs in the same manner that you do with a BMD and so on. So in fact, it is known from QCT studies and so on that on alendronate that you don't see a major increase in the structure of the bone, but you see just a positive maintenance. So in fact, at the end, I have an unhappy face become a happy face. So a nice smiley, and the other side I say, well, that's great then. And I was very happy, just to bracket an anecdote, because I lived that. And then I received a phone call from Italy, and the guy was telling me, you know, I know someone who used it, and they're very unhappy, and they say that TBS is not working. I say, yeah, well, might be, you know, it's not my fault. That's the way it is. They say, yes, because they've been testing the biphosphonate, and they were very disappointed because the effect on biphosphonate was a plateau. So I say, yes, I can show off a bit, because I had exactly the same stories with myself. So I visit Italy on a conference, and then I meet these experts. And when we meet, I was saying, okay, everybody knows that on QCT we have a positive maintenance of alendronate, blah, 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 blah. And then actually at the end people say, yeah, actually we're very happy with TBS. It was kind of a thing where people have false impression that with all drugs, if we increase the density, we'll increase also the microstructure of the bone. And in fact, it was not the case, and it is not the case. So another study that was a subset from the Horizon, from Novartis, and we found exactly the same here. It was a blind study, but a subset with about 30 patients per arm. And what you see the major increase in the BMD and the alendronate after visit, so 36 months here. And what we have here is a placebo was, let's say, decreasing or below negative, and you have a significant plateau on the TBS and the alendronate. So it looks like the response on alendronate seemed to correspond to what we've seen with alendronate. Another study here, it's a subset from the Freedom. Again, it was a placebo versus denosumab. And there was here a nice increase in the BMD, as we used to see, a flat plateau here for the placebo. And for the TBS, we had exactly the same. We had about 2.4% increase after 2 years, well, 1.9% after 2 years and 2.4% after 3 years, which was significantly different from baseline and significantly different from the placebo, which was losing bone after 36 months. So another interesting study that just been presented at the SBMR last year, also it's a head-to-head placebo versus alendronate versus denosumab at a small cohorts, randomized 1:1:1. And you have about 70 patients per arm. And what's happened, it was quite interesting because they had the QCT things. So in terms of DEXA BMD, you had the placebo who were decreasing. You have a major increase after 1 year, about 4.2%, 4.5% with the DEXA BMD of the spine. And you have about 6% increase with the denosumab. So they did QCT, volumetric BMD, and you have also a major decrease in the placebo, and both are increasing slightly more than previously, but you don't have significant difference between those two. You have difference between baseline and between placebo, but not with between the two drugs. And the TBS on this same trial was a significant decrease here in the placebo. You have an increase here, a slightly different, a significant increase, let's say, with difference, with the placebo, but roughly a stabilization under alendronate. And then you have about 2.3% increase with denosumab on a head-to-head study, blindly, of course, for the analysis. So it's quite consistent between biphosphonate, you see a maintenance in a structured, while on denosumab you were seeing some slight increase in the structure of the bone. This is another study that's been published in OI recently by a group from Bern here. Is a head-to-head between Forsteo and Bonviva. And what you see here, again, if I start by the Bonviva, the biphosphonate here, you have an increase in the density and just a positive, non-significant increase or a stable result for the TBS. But you had about 4.3% increase in teriparatide. In other words, you seem to have a double response compared to what we've seen, for example, with the denosumab. So one thing you can react and say, well, you know, the response in TBS is not as large as what we see with BMD. And that's quite logical because we already capture most of it with the BMD, and the structure will play a role only for 10 to 20% of the bone strength. So when you see a small difference, when you see a difference, it won't be a huge difference as you may see with the density and so on. But still, if I calculate the significant gain, stability or significant loss, using the least significant change, as you've seen this morning or if you know about it, and I was not able to calculate that for all group, but with a PTH, we were able to see that 60% of the patient under PTH was demonstrated a significant gain, and about, let's say, roughly, if you combine in both, you have 90% of the patient either stable TBS or a gain in TBS. And you have about 10% who were showing significant loss. If you take ibandronate, then you have 26% of significant gain. Most of them was stable, about 50% in the stability zone, plus or minus 3%, and about 30% of them were losing structure while they were still on BMD. So as a summary, it's a rough summary for treatment without going too much in detail. Be careful, it's not a head-to-head study, so don't take that as a, as a general conclusion, but just give you a smell test, a smell view of what we found is really that on the anabolic drug, we have the highest response with more than 4% after 24 months. You have the denosumab, which is about in between. Then after you have the biphosphonate, which is mostly a positive maintenance, while the placebo in all study are significantly decreasing. Now, I'll just show you briefly, and don't pay attention to the numbers, just to scare you. This comes from Spain, from Del Rio centers. So they presented at the neural presentation in the GSBMR, which is the ACE-BMR for Japan. And what they compare, they have about 80 patients or 40 patients per group, and they compare the naive, so placebo, calcium, alendronate, testosterone, residronate, denosumab, and PTH. And what they found is pretty much what we found with the other studies, in the sense that you have the naive is losing TBS, is losing structure, while the spine BMD was slightly increased by artifact. Calcium vitamin D was really a maintenance, and the rest was positive maintenance. And when you start to go to anabolic, then you go much higher, and you have again here about 4 or 5% for teriparatide. So it seemed to combine in another independent study to show pretty much the same thing. So sorry, if you download the presentation yesterday, you don't have it. If you download the presentation today, you have it, because I updated the presentation yesterday. So having said that, I won't go too much in detail of that, but what you see, if you have more dynamic range here in a BMD compared to TBS, but what is important is a cumulative effect, a positive effect on teriparatide here, for example, where you have a major increase and most of the patients have a significant gain, where on alendronate or anti-resorptive drug here, you have as a majority of the patients are not beyond the least significant change. So it's pretty much the same. I will briefly talk about the high added value of TBS in case of secondary osteoporosis. Some of them go fast because it was already presented. But despite the relatively small number of patients evaluated, seem to have concordant results with several small prospective studies. but there is apparently shown to be association between fracture and TBS in diabetes, primary preparatory retroarthritis, adrenaline syndrome, but if you know how to read it, I don't know how to pronounce it, chronic disease, and also patient with glucocorticoids. So I will just take a few of these examples to show it to you. First is an effect here, also it's a study that was, which will be presented at the SBMR by a Spanish group here. And what they have is patient with glucocorticoid, and they compare a patient with fracture or without fracture here for BMD, and you don't see significant difference between fracture and non-fracture in glucocorticoid patient with a spine BMD, but you see quite a large effect between patient without fracture and patient with fracture with TBS. So it seems that the TBS, the glucocorticoid, had a strong impact on the structure of the bone, which seems to be consistent with many other studies. And even if you take a non-osteoporotic glucocorticoid patient, so that means with a above minus 2.5 T-score, then the BMD was increased, it was not decreased by the glucocorticoid, and you have no significant difference between fracture and non-fracture, while again, where the amplitude is much less, but you still have about half standard deviation decrease and highly significant difference between fracture and non-fracture in a non-osteoporotic group. Now, if you see that in the, well, that's what I wanted to say. Now, another study by Colson, what was presented at the GIO meeting in 2011, if you have a 5 milligram per day or if you have more than 5 milligram per day, the impact on the TBS was much more important. So apparently, it still has to be confirmed in other studies that you didn't see much difference on the density itself, as it is dose dependent, while you were seeing significant difference in the TBS for patient under glucocorticoids. So diabetic, that's quite interesting. So you have seen part of it this morning with John Belizikian. So here it just again on the patient is about out of the 29,000 patients, it was about 2,000 something diabetic patients, mostly type 2. And what we were seeing that on those patients, diabetic versus non-diabetic patients, we see an increase in all BMD parameters where we were having a significant decrease in TBS parameters. And that refer in terms of odds ratio between territory with a disease versus non-disease, which was some kind of a protective effect of the density where we were a risk factor here associated to the structure. So I won't spend much more time as John did that very nicely this morning, better than I can do. But also the relationship with the fracture where TBS in diabetic patients could predict the fracture, even though the BMD was also able to do that, but with the shift that it was demonstrated this morning. Another study that was presented and published in Osteoporosis International in 2014 is by a group in Syracuse, and I was showing you exactly the same thing, that you have non-diabetic patient, the spine, TBS, and a diabetic type 2 patient, you have a significant decrease between those two, even adjusted for BMI and all the factors, and even adjusted for age and BMI, but also after adjustment for BMD. And what was even interesting in that one is when they control with a glycemic control, those who were below 7.5% versus above, then you have a significant difference between the TBS and no difference between the BMD parameters. So apparently the level of glycemia was also playing a role. I'm not a specialist how to explain that, but apparently that's what they reported in the paper. So let's go to the fun part. How to use TBS in clinical routine. So just few leads compared to what have been done in different countries and the way they're approaching it. First of all, the way it looks like as a TBS report, it looks pretty much like a DXA report, where you have the image, you have the DXA image that you've been doing, and the overlying calculation of TBS on top of that, because the region of interest that you will have defined for the BMD will be copy to the TBS algorithm so that it will be exactly the same region of interest. So if you screwed up the BMD analysis, that will screw up the TBS analysis. Keep in mind the GIGO approach, garbage in, garbage out. So if you do good things, you'll have good result on the other side, exactly the same. Although TBS might be more sensitive to positioning because you're projecting holes, the projection of the holes if you have rotation will be more sensitive compared to the density itself. So you have numbers which represent L1 to L4, and you have the reference curve and the different combination. Also, the BMD can appear in the reports. So what I've been said from the review, there is roughly, if you divided the population of race per tertile, so lowest tertile correspond, if you have a TBS below 1.2, it's considered as a degraded structure. If you're between 1.2 and 1.35, it's partially degraded. If you're above 1.35, you're considered as a normal structured. Cells still do need to be fine-tuning, but roughly the number of that. So the question is, if you have a patient, we have about the same DMD, and you start to have quite different structure of the bone. The texture is quite different. So one will have a good structure versus a bad structure. Would you manage your patient differently? Now, given the level of evidence behind, obviously, if you have a patient which are highly degraded versus normal structure, then that will influence your decision on what to do with that. So there is a Spanish approach that is working on it. They decided to combine and use a T-score approach, and they use the BMD T-score and the TBS T-score here. And they found out that, okay, depending if you have a low TBS or low BMD, you may end up in a high-risk group. And they're also using that when they're giving treatment, because they will look at how the patient are evolving over time. That, for example, if you are here a patient which is degraded in terms of density and structure, they're giving a treatment that will influence both the density and the structure of the bone, and they will expect the patient to move toward that direction. If you have here a good structure and a bad density, you will give a treatment that will move toward that direction, and you're happy if you maintain the structure but you improve the density. So that's a model that the National Osteoporosis CM Foundation in Spain are working, and now they try to validate that in clinical routine with multiple centers, but that the algorithm they're about to test. You have what we're presenting here is adapted from the Manitoba study, and that's quite interesting. That comes back to the overlap between fracture and non-fracture in the osteopenic zone. Here, if you have BMD alone, that will correspond to, let's say, a low level of fracture, risk of fracture, medium, intermediate level of fracture, or high level risk of fracture. Now, if you do that and you split after you have done the BMD, you do the TBS, then depending on the TBS value, according to the threshold I gave you just before, you will ending up by having a color map here that will give you the sense whether or not the level of risk of your patient, that will fine-tune somehow the level of risk of your patient. And for example, here, if you have an osteopenic zone with a low TBS value, you will be at exactly the same level of risk that a patient with osteoporotic with a normal TBS value. So you just start to fine-tuning the approach of the level of risk with the patient. Another way to do that, I leave that in German so that you understand it's German. So that's a German approach, and they include that in the DVO Guidelines. So that means just recently, actually, it was approved just a few weeks ago, just a month ago. And what they have, they don't like FRAX. So they say 999999 to FRAX, okay? So they put that 9999 into the table of level of risk, where if you have a certain number of clinical risk factors, then you have the BMD here, you have the man, and you have the Frau here, okay? And then depending on the number of clinical risk factors you have, every time you have a clinical risk factor, you will shift your level of risk, and that's the therapeutic threshold. So 999 may become ya. So it looks like you're still following me for now, so that's good. After, 40 minutes. So when you have that, now they include the TBS, and they're saying that if you have a TBS at a low value, defining by Z-score, at a certain level, they consider it as a major fracture risk factors, and then that means that all these 9999 here, if you have a low TBS value, they will shift their patient to the and they will treat the patient on the basis of the higher fracture risk. So, we talked a lot about BMD, very little about clinical risk factors. So we talked about the DVO guideline, T-score approach, gradient of risk, different things like that. But what about FRAX? Are we heading to FRAX? If you look at here, again, from the Manitoba study, the first thing we look at with Bill Leslie is whether or not the TBS was providing information independently of the BMD, but also independently of the FRAX clinical risk factors. And what he found out here is that that was published in GCD in 2012, just do advertising for clinical densitometry journal. So that's, you have a negative impact of age on TBS with no adjustment for BMD, and all the clinical risk factors, that you have in FRAX had an impact on the TBS value. Even when you adjust for spine BMD, the effect remains. Even we adjust also for femoral neck. So in other words, apparently from that preliminary studies, it looks like the TBS was bringing something more than just BMD and on top of clinical risk factor that was introduced into the FRAX model. So having said that, it came out even with Canis and Co. So that was a touchy issue. But it came out with, okay, let's try to find out whether or not the fact to use TBS as a FRAX modifier, you could potentially influence the FRAX outcome. And there was a preliminary model here that was presented last year at the ICD meeting and also at the ASBMR, when you consider the intermediate tertile, which means between 1.2, 1.3, and versus the lowest tertile and highest tertile, you have quite a major impact on the FRAX probability for major osteotic fracture and hip probability. In other words, if you have a very low TBS value, you will increase your FRAX probability by 25% or 30%. If you have a good TBS value, you will decrease your FRAX probability by 20% for major osteotic fracture and almost no change for hip fracture. So it's early simplified model, so that will not be the final model, but what does it mean? That means if you consider here for the French FRAX intervention threshold, where you have a threshold here for intervention threshold, potentially all the patients around that line could move from above the line to below the line, or from below the line to above the line, depending on the value of TBS. So truly, a TBS is a FRAX modifier things. So if I give you an example with a French recommendation, so this time is not German, it's not 999, it's oui, no, no, no. So it's try to be educative. So that's the French guideline. What they say that frankly, it's a bit weird because they don't consider wrist fracture as a severe fracture, whatever. But it's a 75-year-old woman, wrist fracture, she's smoking, and BMD T-score is minus 2.5 and 2.6 here. So that means the patient is osteoporotic with wrist fracture. So supposedly, you're supposed to treat the patient. But with their recommendation, they say, okay, wrist fracture, yes, so it's not a major. So you want to go with a BMD. If the BMD is above minus 3, so which is the case with minus 2.6, then you're calculating the FRAX. And depending on the FRAX value, you treat or you don't treat the patient. So if we take that patient and you look at that one, she's bagarre, just under the therapeutic threshold. Why most of the clinicians that you are, with that age, osteoporosis, wrist fracture, plus your other risk factors like smoking, you will intuitively have treated that patient. But with their guidelines, you don't. You expect the rest. She had a TBS. TBS 6 Australia, that was the old TBS report, but that's still. TBS was extremely low. If we apply the FRAX adjustment thing by 25%, as it's very low, that will move the patient from below the therapeutic threshold to above the therapeutic threshold. It's still a FRAX. That means the adjusted FRAX move from 18.5 to 22.5, and then you will treat the patient with the appropriate drugs depending on the profile of the patients in France. The patient we mentioned today, before at the beginning, you remember the 70-year-old lady, she was FRAX was 1.5 and FRAX 21%. So that was affirmative treatment. Would you treat or would not treat that patient? So it happened that this patient was having a very good TBS values. And that TBS value was 1.35, which is absolutely normal for her age and so on. So that means normal is 21% decrease for FRAX major osteopenic fracture. So that moves the FRAX to 16.6, but no impact on FRAX hip fracture. It was 0. So no adjustment. So that means that patient will move from above threshold to below threshold. So in that case, according to, if you apply strictly the guidelines, then you will not treat that patient. So now we go, and I almost finished, so you can go for a coffee after. If you go beyond that point, it's nice to have the FRAXing, but it's more like a pseudo model. So the next step was really to go into the FRAX model and having John Canis and Jensen, or the work group, absorb the data, work in their black box, and come out with something that will be consistent or coherent with the model they developed. And before they did that, it was the first study, again, by Bill Leslie with the Manitoba, where here you look at this, the type of graph you've seen before, but instead of BMD, it's a major osteopenic fracture per tertile versus TBS. And again, you were seeing that combining FRAX and combining TBS are improving the fracture probability or the prediction of the fracture. So having said that, when John Canis and co. have been seeing the result that by combining FRAX plus this is really improving on very large cohort, they were willing to take the data from a meta-analysis and dig a bit further. So I just paired that one, but just showing you that the TBS adjusted for clinical factor plus femoral neck BMD plus lumbar-spine BMD was remained significant. So having said that, it came out, and that been published just in June, is Osteoporosis International. It's just providing a new model of FRAX, which was a FRAX modifier again, where for a BMD T-score of -2 or +1, depending on the fracture probability, so that means depending on the value of TBS, you will have an influence which vary a function of age and the death hazards will have to, they take that into account, and that will influence the FRAX outcome. And what Bill Leslie demonstrated is that you improve the calibration in FRAX, especially in a younger age, where calibration sometimes might be an issue between the expected and the observed. So that combination of FRAX plus TBS are improving things. So as you know, when you develop a new model, you can't just say, I have one study and I develop a worldwide model. So in order to do that, you take one big cohort, you develop a model, and you cross-validating it in another one. And there is an ongoing project that been started at last SBMR, is individual level meta-analysis with 14 cohorts from around the world. I show you preliminary result for men and women that Bill Leslie did. Is not the final meta-analysis, but result looks quite good. Here for women, if you adjust the TBS, just the FRAX clinical risk factors is 1.4. if you adjust the TBS by FRAX clinical risk factor plus spine BMD, it remains highly significant. If you add on top of that FRAX plus spine plus hip, you still have another ratio of 1.3, which is 30% risk of, you have a 30% improvement. For men, it's even better. It was quite surprising because the Manitoba in men didn't work so nicely. But on FRAX, you have 1.8, 1.5, 1.55. In other words, adding that into the meta-analysis, at least in terms of gradient of risk, you will improve the gradient of risk. And that's where they're working now on a final model to integrate the TBS into FRAX. And down the road, probably by early next year, will FRAX on the FRAX website, we'll see a TBS button for TBS adjustment, which will be something like age-dependent and value-dependent, so it'll be much more complex compared to what I show you with the 25%, 20%, and so on, because that will be age interaction. And what is quite interesting is the impact of TBS on the FRAX is much larger in a younger age compared to older age, where you can almost double the FRAX value at a younger age, which somehow makes sense, because if you have extremely low value when you're young, that means you really get something bad, and it's likely related to secondary osteoporosis or something like that, and that should trigger an approach of your patient slightly different or request additional analysis. So in conclusion, if you can still hear that, I will make it in French so that you will concentrate yourself to listen it. Il y a assez d'évidence aujourd'hui. I was not bluffing. No. So there is sufficient evidence today to use TBS in clinical routine, and actually more and more people are doing it. While the optimal threshold still need to be fine-tuned, there is an incremental increase of improvement of fracture prediction and so on when you combine spine and BMD and clinical risk factor and or FRAX. And when it be cross-validated into this meta-analysis, then it will be kind of a global approach of validation. And the good thing about if you can integrate it one way or another, the FRAX already, is that you don't need to redesign the current guidelines, because that's happening. You're just taking the adjusted value of FRAX, and that's still the same. And ICD will hold a position development conference this year, well, at the annual meeting in February in Chicago, where you're all most welcome to attend, on the TBS amongst other parameters like hip strength analysis, FE, and so on. And also IOF, EKO as having a position paper working group also that will release something toward the end of the year or early next year as well. Having said that, before thanking you for your attention, you know, we've been beating a bit DXA hard and saying, you know, DXA, it's only DXA, it's only BMD, and so on. But I think we just can optimize what we have DXA. And DXA is not just DXA, it's not just BMD. And we're lucky enough by DXA to have 5 technology into one. And it depends if you want to think business-wise. Business-wise, you will develop 5 different technology and sell 5 different technologies. But if you want to think clinical routine, you try to optimize, integrate as much as you can into what you already have in hand. And that's the case with DXA, because you have 5 in 1. It could be almost 6 in 1 with the atypical fracture capability, imaging capability. But you have the BMD. You have the microarchitecture with a hip strength analysis or the femoral neck length and so on. You have the TBS. You have the VFA things. And you also have the body composition, as you were able to learn yesterday from Neil Stark with sarcopenia, that fracture is not only density, it's not only microstructured, it's also muscle weaknesses, and we should integrate that, and that's already integrated into one technology. Now, if you dare asking any question, you're more than welcome. Thank you for your attention.
Thank you very much. Do you have any plans to analyze the anti-sclerostin antibody scans?
Yeah.
Okay. And do you see a way to...
Well, actually some analyses have been done. I don't have the data because it's been done in a blind manner, but I guess that down the road they will just do the analysis and so on. That was done recently. So we'll see. It's reacting. How much I don't know, but it does.
And this question is for both you and for Dr. Belazikian. Do you see a way to work with the BioDent? The BioDent preferred site right now is the tibia, but do you see a potential for combined?
To combine with TBS or combine with FRAX?
Combine or validate.
My experience from developing a product from university to a final product, it takes a lot of time because you have the technical validation, you have the clinical validation, and the most trickiest part, which is very tricky, is medical acceptance and patient acceptance. And it's kind of a married together. And that takes a lot of time. And nano indentation seems to provide good information about bone strength and so on, but it's not yet into it's required certain kind of I wouldn't say it's not I don't know if it's painful or not. I'm not quite sure. I want to try. I will ask first John whether or not it's painful after he tried himself. But patients tend to avoid as much as they can when you have to be kind of operated, even if it's only 10 minutes and so on. So whether or not that will be part of the clinical routine, I'm not quite sure. Whether or not it will be part of a clinical routine in very specific population where you need an extra information, then I'm pretty sure that it will be. As we were doing bone biopsy in certain class of patients, then why not doing indentation? Because that's clearly less invasive than a bone biopsy. So why not? Maybe you want to add on to...
Well, no, I don't. Obviously, it could, Mary. We don't know what this microindentation technology is measuring. It is measuring something. And again, it remains to be seen. It's going to be very labor intensive as the TBS development was. So I think we'd have to wait. Margie, you were ahead of me, so you ask your question.
I think one of the most exciting pieces of the data that you presented was how effective this was and John also, in diabetes and picking up fracture risk and deteriorated microarchitecture. And this could solve some of our clinical problems with FRAX in that diseases like diabetes, maybe COPD, drugs, and other things that aren't included in FRAX may now be included by using TBS. So the question I have is, anyone looked at TBS in, say, SSRIs, which we know in most studies have shown doubling of fracture risk, but that's not included in FRAX, and a disease like COPD where there's very high incidence that's not necessarily picked up by just BMD measurements alone of incidence of fractures.
SSRI, I think there is one study, I don't recall exactly, I think a group did it as an abstract. I think they even presented last year at the SBMR, I'm not quite sure. Getting confused because that's getting almost out of control number of people doing abstract on it. On COPD, we have looked at in Bill Leslie in Manitoba's cohort, and there is a relationship between COPD and the TBS. But it's not at the level we'd like to see as a design-specific D9 study on that. I haven't seen any study yet on that.
Two questions. It is really intriguing that the relative value of TBS seems to be greater in the younger population. If I could, maybe that's not the way to put it, but you're getting additional information, and the older, not that it's not valuable in the older subject. So that may be very helpful in the younger individuals. The other question, or this is a question, Didier. So if it becomes part of FRAX, and FRAX is country specific, not just in terms of mortality data, but in terms of the interaction terms among these different factors. Will TBS have to be tailored and looked at from a country point of view?
Well, actually, that's why they had this individual level meta-analysis that include already China, Japan, US, Europe. So different countries have been included in it. And they have looked at the hazard ratio with bone, with fracture and death hazards. So I think in their black box, they've been taking that into account and check the interaction with the different countries' ethnicities, whether or not they could include it. For what I heard, I haven't seen it, but what I heard, apparently there is a fairly good homogeneity in the impact of TBS and interaction with the different factors according to the different cohorts, where they use the I2 modeling for homogeneity, and apparently was pretty good. I can't tell you more because I don't know more about it. I guess we should hear more. Apparently will be, they're currently writing a paper, so that should be published or at least submitted by in autumn sometime and should be released by the end of the year. But the fact that there is more influence on younger population, that goes to the presentation we had yesterday, and the idea of last night cocktail, and where in perimenopause or young menopausal women, where they have apparently normal BMD and they're having troubles, so also osteoporosis or fracture. I mean, maybe part of it could be captured and something there. I can't extrapolate until we have a solid data to demonstrate that. But we already agreed that we'll go for a project, and maybe down the road we'll have the answer. But clearly, from the interaction with age and so on, there is more influence, and there is so much comorbidity anyway when you're getting older that you can almost take a spoon and say, well, I can predict the fracture. That'd be about the same, because everything is giving about the same information, just all melted together. So you're losing differential effect of the factors when you're getting older, while when you're younger, then you can identify the one who can have the most influence. Yep.
For a given BMD or T score, will you get the same TBS score on hologic versus GE?
In terms of in average, it will be yes. Now, in terms of correlation, there were a nice poster from Diane and Neil that was presented last year. The correlation, the slope will be slightly different between a Prodigy and IDEXA, and that will be the same between a Prodigy and a logic machine. In average, the result will be the same. As an individual level, you have to be careful. And that's pretty simple, because all model working with different energy, working with a slightly different resolutions. You can have a poor resolution, very good resolution, or extremely good resolution, and that will have some impact. So you can't degrade a good resolution to looks like exactly a poor resolution. So in average, we take that into account for calibration. That's why when we're installing the software, we have a calibration phantom, so that we try to match it as much as we can. But you always have to be careful at the individual level when you see a patient, as you do with the BMD, even though the difference will be smaller. Yep.
Where do you stand with the application of TBS in the class? What was the question?
I understand the beginning, not the end.
Proximal femur.
Oh, proximal femur. Yeah. We had some good results. I shouldn't share that with you. It's supposed to be, but we're a group of friends. Okay. The femur is much more complex, in a sense that in a vertebrae, you have a preferred orientation of the trabecular, mostly vertical, and then you have the horizontal trabeculae, as it was nicely seen on the ILS approach that John mentioned before. And a femur is a big mess. In a sense, you have trabecular orientation goes in all directions depending where you are, and you have a cortical thickness which is very thick. The problem is, from a texture point of view, the evolution of the cortical thickness and the trabecular will change at different speeds, which means that if we apply the TBS that we do right now without optimization, you will see a U-curve, well, not a U-curve, an inverse U-curve, where you will have the TBS that will increase with age till a certain point, and then that will decrease around 75 or 80 years old, that will decrease with age again. So it goes up and down, which could be confusing. And in fact, there is a rationale behind that, because at the beginning you have so much dense bone that as a texture, it looks very homogeneous, and as if you were having a plain bone and no texture. So the value of TBS will be low. When you start to have a thinning of the cortical bone, some part of it, then you start to see the texture, and you will say, oh, finally texture, so it go up again. And then when the texture will start to disappear, then you will see hole, it will go back. So in other words, it's more complex, and I don't think a TBS and a femur is ready for prime time now. It will require more research, and maybe in 2014. And there is already so much to validate and to find out with the AP spine scan that we left that aside for internal research and see what's happening down the road. That was a long answer for a short question.
Thank you.